Welcome back. So we are in the next part of our lecture on preterm labor, and actually we are discussing PPROM. So we were discussing in the last part what are the common causes of oligohydramnios. First, we said that fetal anomalies, especially related to kidneys, they can cause oligohydramnios. Second is intrauterine growth restriction, and mainly depends on the underlying cause. Especially if it's placental cause, yes, there can be oligohydramnios, but there are some infections, fetal infections, which can cause UGR and oligohydramnios at the same time. For example, even torch infections. But sometimes, say, for example, cytomegalovirus can cause oligohydramnios, but it can also cause polyhydramnios. Okay. And then why I am discussing about oligohydramnios is because premature rupture of membranes, whenever there is premature rupture of membranes, women, most of them, of course, they can have oligohydramnios. Okay. And then there are some drugs, for example, non-steroidal anti-inflammatory drugs, because they can affect the kidneys of the baby, so they can also cause oligohydramnios. As a general rule, so if there is a patient, even if she does not has any complaint of vaginal leaking, if she has not noticed any vaginal loss of fluid, even then, if on ultrasound we see that it's oligohydramnios, so we have to do at least two things. First is measure her blood pressure. Okay. Secondly, of course, we need to check the growth of the baby, and we have to perform a speculum examination to make sure that she did not had any leaking. Okay. So, how do we know that a baby has pregnancy has oligohydramnios? So it's by we use these terms. First is called amniotic fluid index, or which stands for which the abbreviation is AFI, or sometimes people also use DVP, deepest vertical pool, or MVP, the maximum vertical pool. So what does this mean? See, so before I proceed, just look at this pregnancy and this pregnancy. So this blackish thing, black on ultrasound, that means fluid. Okay. So in this case, we know that there is amniotic fluid around the baby. So this is a pool of liquor. Okay. And then there can be other pools of liquor right here, here, and even here, right? And if you compare this pregnancy with this one, this baby looks kind of stuck, right? So compared to this pool of amniotic fluid, this one looks very minimal. Okay. So this looks oligohydramnios, but this is, if I, without measuring this pool of liquor, if I just simply say this looks small, it will be subjective. I need to measure it to make it objective. Okay. I'll come back to this slide, but how do we measure amniotic fluid index, or the deepest vertical pool? So you see, this is just one pool of liquor. If I place the cursor on the of ultrasound here and measure it from here to here, the ultrasound automatically will give me whether it is 4 centimeter, 5 centimeter, 6 centimeter, or whatever it is. Okay. So to measure AFI, we have to measure the amniotic fluid pools in 4 quadrants, 4 corners of the maternal abdomen. 1, 2, 3, 4. And it should be the probe, the part of the ultrasound thing, which is placed on the abdomen of the woman. That's called the probe, right? So the probe is placed vertically, not transversely. Okay. So I have to measure 1, 2, 3, and 4, and ultrasound machine gives me the readings. And now I have to see which one is the deepest. Okay, so that will be the deepest vertical pool. For example, if this in this corner, if it was 2 centimeter, if it was 3 centimeter, it was 4 centimeter, and this one is 5 centimeter. So which one will be the deepest? 5 centimeter. Okay, so one way of reporting is just tell us what is the deepest vertical pool. That's it. More commonly is amniotic fluid index. What does amniotic fluid index means? The ultrasound machine automatically adds up. When I measure all 4 quadrants, it automatically adds up, like 2 plus 3 is 5, 5 plus 5 is 10, 10 plus 4 is 14. So it will say AFI is 14, and deepest vertical pool is whatever was the biggest one. Okay. So now how do we label oligohydramnios and polyhydramnios, right? So normal AFI, amniotic fluid volume, is the AFI should be between 5 to 25 centimeter. Okay, so AFI. Okay, but if we are taking the deepest vertical pool or the maximum vertical pool, then if Yeah, so in AFI, if the AFI is less than 5, that's oligohydramnios. If it is more than 25, that's polyhydramnios. Actually, most books write 24. Okay, so 25 and more is polyhydramnios. And for the maximum or deepest vertical pool, if the in one pool we see that the biggest one, if it is less than 2, that's oligohydramnios. If it is more than 8, that's polyhydramnios. Okay. So that's the thing. Either use AFI or use the deepest vertical pool, whatever. Okay. So that's it, right? So here we can see 4 quadrants: 1, 2, like 4.5, 3.6, 5.1, and 3.2. So in this one, deepest one is 5.1, and the AFI will be a sum of all 4.5 plus 3.6 plus 3.2 plus 5.1. Okay. So now, why it is important, why it's not good to have preterm, pre-labor rupture of membranes, it's because it complicates almost 3% of pregnancies, and it is so there are two main complications. Okay, first is the woman can go into preterm labor, and the second one is she can develop infection and inside the uterus, right? So chorioamnionitis. These are, remember, these two main complications. Okay, she can go into preterm labor, and secondly she can develop infection inside. So now in secondarily, now you know what are the complications of having a preterm labor, right? Preterm delivery. So just tell them all, like intraventricular hemorrhage, respiratory distress syndrome, increased perinatal mortality, increased risk of neonatal death, increased risk of necrotizing enterocolitis, increased risk of kernicterus, increased risk of sepsis, and everything. And that's the thing, right? So the patient ultimately, the baby can be delivered prematurely. There can be infection of the mother and the baby. There are increased chances of having sepsis both for the mother and the baby. Now, premature babies are mostly, many of them, not most, but many of them, they are more likely to be in a breech or some other malpresentation. Okay, and with malpresentation, there are more chances of having a cord prolapse, especially with breech or transverse lie. Okay, when babies are born very preterm, so if PPROM happens very early on, especially less than 24 weeks, then they are more likely to have placental hypoplasia, pulmonary hypoplasia. Especially there is a syndrome which is called Porter's syndrome. That means that usually happens very early, because some women can have PPROM as early as like 19 weeks, 20 weeks, right? So even before there is fetal lung maturity. And then, so whenever there is PPROM, a recognized complication is placental abruption. So first they can have rupture of membranes, followed by placental abruption. That can happen at the same time or even later on. Okay. So what is the best test to diagnose PPROM? Okay, first of course we will take history, but that may be suggestive. It may be just a leakage of urinary incontinence, right? So what test is the best? It's just on examination. Just perform a sterile speculum examination, and please make sure that when there is PPROM or even PROM, avoid unnecessary digital vaginal examinations, even if we are using sterile gloves, okay, because we can introduce infection. Okay, so first perform speculum examination, because speculum examination is safe even if there is a placenta previa. So what are we looking at? Just see if there is pooling of liga on the posterior blade. Like, do you see any pools of liga, right? So that's just confirmatory. If you see that, there is no other test needed to confirm the diagnosis. But yes, we will take a high vaginal swab and send it to the laboratory to see if there are any pathological microorganisms. Okay. Now, if a patient says that I had this, like the history is strongly suggestive, like she says, no, she had a leakage of fluid, right? On ultrasound, if we perform, there is oligohydramnios. And then if on a speculum, sometimes it's that we do not see it, any clear pooling of fluid, okay, any pooling of fluid. So although even this history and clinical features are strongly suggestive, then what will we do? We have a test actually. Okay, so we have a test, I will talk about it, but we can confirm that. But if we see this pooling of liquor, that's it, we don't need further testing to confirm the diagnosis. Okay, now, if we see liquor there, we have to know two, three things. First, is it foul smelling? Because foul smelling liquor is a sign of chorioamnionitis. Okay. Secondly, what is the color? Okay, is it meconium stained? Is it greenish, or is it blood stained? Okay, because remember, the baby might have passed meconium, or if they're not doing well, or it may be that the patient is started to have placental abruption now. So if the history was strongly suggestive, and but if we could not see on speculum examination any liger, then what we have to do, we have to do this test. Okay, it has many different commercial names, but basically what does it do is it checks these proteins mainly. Okay, so there are different names. One of the common brand names is amniosure. Okay, amniosure. Okay, so this test basically at the time of speculum examination, again we take this kind of a swab, we put it in this tube which has some fluid, and then this thing goes inside, it is dipped in that fluid. So if there are two lines like a pregnancy test, that's positive. If it is just one line, that is negative. Okay, so you do not even need to remember the exact name of the protein, but it detects the proteins which are present in the amniotic fluid. Okay, so now the next scenario is a primary gravida at say 28 weeks presents with low abdominal pain. There is a history of a sudden gush of lica which was clear. She is unsure if it was urinary incontinence. What should be the next step? So what will you do here? We will perform, of course, we will do vitals, right? Because in chorioamnionitis, what will happen to the vitals? There may be tachycardia, there may be hyperthermia, or even sometimes in sepsis patients can have hypothermia as well. Initially, it may not be full-fledged, right? So initially, there may be simply the patient may have a little bit of tachypnea, there may be tachycardia. Later on, she may develop hypotension, and if we have put our hand on her abdomen, we will feel tenderness. Okay, suprapubic tenderness. So these are all signs of chorioamnionitis. But to confirm the diagnosis, what will we do? We will here perform a speculum examination. Okay, so now I think it says on speculum examination, what are we going to see? Os, right? Cervical os is closed. That means she is not in labor, but she can go into labor, right? Because now, okay, so os is closed and no pooling of liquor. Okay, so we did not see any pooling of liquor. Now here, see, this history was strongly suggestive. Okay, she says I had a sudden gush of liquor. Okay, and then of liquid, right? Now history is strongly suggestive, but speculum there is no pooling of liquor. So what should be the next step? Then we will do that amniosure test. Okay. Now, this is another one, another case scenario. On a routine anomaly scan, the sonologist notices that there is very less amount of fluid around the baby, which is maybe oligohydramnios. The rest of the scan is normal with normal anatomy. That means there is no congenital, and hopefully there are no anomalies, right? Although we cannot be 100% sure, but still. She referred the patient to the obstetrician. What should be the next management step? We can discuss this in the class, okay? If we have time, we will discuss this history. What should we ask in the history? What should we ask in the examination? When should be the investigations? So just if we don't find time, I'll tell you here. In history, basically, whenever there is oligohydramnios, what do we do? First, check her blood pressure. Okay, anomaly scan and the rest of the baby's biometry has been done, so there is no growth issues, right? So it's just oligohydramnios. Then our suspicion of PPROM is increased. Okay, because see, if her blood pressure is normal, fetal biometry is normal, and it's only oligohydramnios, we definitely have to rule out PPROM. Okay, so in history, then we will say, okay, did you notice any gush of fluid? If she says yes, then we will say, okay, when did it happen? What was that amount? Did you notice the color? Is the baby moving well? Right? If she says no, I did not notice any leaking of fluid, that's it, right? So then in examination, depending on, so if we are suspecting PPROM, then what will we do? Mainly, yes, we will to check vitals, we will do an abdominal examination to check suprapubic tenderness, but the main thing is perform a speculum examination. Okay, and then depending on the speculum examination, we will perform investigations, which we will talk here now. Okay, so rest I will discuss in the next one.